high-flow oxygen delivery systems. Now, high-flow oxygen delivery systems have a flow rate that meets the entire oxygen need and tidal volume, regardless of the patient's breathing pattern. These systems are used for critically ill patients and when delivery of precise levels of oxygen is needed. The table for comparison is on page, wait a minute. The table for comparison of high-flow oxygen delivery systems and their nursing interventions you'll find on page 534. So let's talk about the different types. The Venturi mask is a mask that's used a lot of times with your chronic lung disease patients because it can deliver a very precise amount of oxygen concentration. And it has this little adapter between the mask and the oxygen source where you can dial the percentage of oxygen needed for that patient into it. These patients are usually able to be switched to a nasal cannula for mealtime, but it's very important that we make sure that we come back to switch them back to their Venturi mask after that meal is completed. They don't need to stay on that nasal cannula for too long. Some of the nursing interventions when using the Venturi mask is to make sure that you keep the orifice for the Venturi adapter open and uncovered. And what they're talking about is if you look at figure 28.6, the where it says the air entrainment port, that's where the air is coming in to make the percentage of oxygen, and that that port needs to make sure that that port is opened. You also want to make sure that the mask fits snugly and that the tubing is free of kinks. We also want to make sure that these patients can be very prone to drying out of their nasal mucosa, and you want to make sure that, remember, we don't use anything oil-based to lubricate those dry mucosas. We use a water-based lubricant, like an oral wash, to do that. We don't use Vaseline. Big thing with the Venturi mask is make sure that we know that able to switch to nasal cannula for mealtime, that it can give a very precise O2 concentration. It's best used for your chronic lung patients and those nursing interventions in table 28.2. Now, I'm kind of putting the cart before the horse here, but we're going to talk about the T-piece, which delivers desired FiO2 for your tracheostomy patients or patients who are intubated who they are working on extubating. This ensures humidification through the creation of mist. The mist should be seen through inspiration and expiration. The table again, 28.2, talks about how the T-piece can be between 24 and 100% FiO2 with flow rates of at least 10 liters per minute, providing high humidity. You'll get condensation from that humidity in your tubing, and you have to make sure that you keep that condensation cleared out of your tube. Keep the exhalation port open and uncovered. Position the T-piece so that it does not pull on the tracheostomy or the endotracheal tube. Make sure that the humidifier creates enough mist. Remember, you should always be able to see mist both on inspiration and expiration. And Miss Stone, when you're in lab, will be able to show you a picture of that. Big things, though, with the T-piece is known that they're used for your trachs and when you're trying to get someone extubated when they are intubated, which you'll learn about more about in 495, but that you also make sure that you have the mist. You should see it both on inspiration and expiration. Make sure that that condensation, when it collects in the tubing, is emptied. And just look at those rationales and interventions in table 28.2. That will do you well. We're now going to go on to talk about the non-invasive positive pressure ventilation. Using positive pressure ventilation to keep the alveoli open improves gas exchange without the need for airway intubation. Non-invasive positive pressure ventilation can be delivered using both either oxygen or just on room air, depending on the needs of the patient. The patient either can wear a nasal mask, which is shown here in the picture on the PowerPoint. Sometimes they use a nasal pillow, and sometimes it's a full face mask, which covers both the nose and the mouth. There are 3 most common modes of delivery using the non-invasive positive pressure ventilation. They include CPAP, which is continuous positive airway pressure, which delivers a set positive pressure through each cycle of both inhalation and exhalation. Okay? Then there is the volume limited or flow limited, which delivers a set tidal volume with the patient's inspiratory effort. And then lastly, we have BiPAP, which is the pressure limiting, which includes both pressure support, pressure control, and bi-level positive airway pressures, which cycles differently from pressures of inspiration and expiration. With all that being said, the things I want you to know about BiPAP is that BiPAP has different pressures for both inhalation and exhalation. And the CPAP is continuous. It is the same amount of pressure both during inhalation and exhalation. So that's the difference. Is BiPAP has 2 different levels, and CPAP has the continuous levels. Like I said before, CPAP delivers set positive airway pressures throughout each cycle of inhalation and exhalation. What it does is it opens collapsed alveoli. It's used for both sleep apnea, after surgery, and for cardiac-induced pulmonary edema. But it is not helpful for patients with respiratory failure after extubation. Again, it is not helpful with patients with respiratory failure following extubation. People will be placed on either CPAP or BiPAP sometimes when they're in palliative care to relieve dyspnea, including patients with a do not intubate order. Sometimes this practice is controversial. Some providers and families feel like it's too close to an intubation, while others find the patient will find comfort and not have as much air hunger using a CPAP or a BiPAP machine. Okay, guys, full disclosure, I've never seen a transtracheal oxygen delivery system. So please make sure you speak with Ms. Stone when you're in lab. And I Googled it, but it's a long-term delivery of oxygen directly into the lungs. It's a small flexible catheter, and it's placed into the trachea through a small incision. And so it helps to avoid the irritation of the skin from the nasal prongs and also from the drying of the air, like the air. The rest of the mucous membranes won't get so dried out. They can do different flow rates based on whether or not the patient is at rest or having an activity. You have to take it out to clean it, and the patient uses a nasal cannula when this tracheal oxygen delivery system is not in place. And that is all of my knowledge on that. And I Googled it. There's some interesting articles on how it's used for people who have long-term need for oxygen, who were having trouble with using because it can be more of a precise delivery than using a nasal cannula is what it sounds like to me. I'll try to get some more information on that, but don't anticipate a question on it. Lastly, we're going to cover home oxygen therapy. Now, with home oxygen therapy, there is a criteria for equipment. For Medicare to cover home oxygen therapy, the patient must have severe hypoxia, defined as a partial pressure of arterial oxygen, the PaO2, level of less than 55 or an arterial oxygen saturation of less than 88 on room air and at rest. The criteria vary when hypoxia is caused by non-pulmonary issues or when oxygen is needed only at night or with at rest. You'll see this a lot. Non-pulmonary issues that may need home oxygen therapy can be a lot of your heart failure patients, patients who've had rheumatic fever, who now have rheumatic heart disease. These patients a lot of times will require oxygen therapy either at night or when they're exercising. Now, remember, when we're talking exercising, we're not talking about running a marathon. We're talking about bathing or, in order to, cook a meal. They may require oxygen when they're having more endurance. Patient education is crucial when you're talking to a patient about home oxygen therapy. A lot of times these patients have been longtime smokers. You have to make sure that they understand that they cannot smoke in a room that has their oxygen tanks in it or their air compressors. You need to make sure that they have enough oxygen canisters if their electricity goes out and their oxygen concentrator is not available. You also need to make sure that the patient understands to make sure that the O2 tubing doesn't get kinked, or that they don't trip over it or trip their spouse with it, because this can be very dangerous. You want to make sure that they don't try to place it underneath rugs, things like that, and then when it gets compressed when people step on it. You need to make sure that they have a sign that says that oxygen is in use in the home and not allow anyone to smoke inside the home. This can be a big psychosocial issue if the patient's a smoker, their families are smokers. They can feel very isolated. They can feel like they're not welcoming to family because they're all of a sudden not allowing them to smoke in their house. And this can be a big deterrent for people to actually use their oxygen when they're themselves are still smokers or their family are smokers. It could be a big problem for this patient to having anxiety because they can't smoke at their home anymore or their family can't. The types of home oxygen therapy, a lot of times, depending on your insurance, will depend on which type of oxygen delivery system that your patient gets. The compressed gas in a tank or a cylinder, like the gentleman who's being assisted to walk there in the hallway, a lot of times is used when it's portable, for the portable use, along with the oxygen concentrator, which we don't have a picture of, which is like a big box that requires electricity, and then it concentrates. I don't know how it works. I'm not an engineer, but somehow it uses regular room air, concentrates it down to deliver O2 at liters per minute through a nasal cannula. And it has a little flow regulator, just like the oxygen regulators on the wall in the hospital. Because they require electricity, a lot of times these patients, are put on the power company's first response list, so that if their power goes out, they make sure that their power gets restarted. And we always want to make sure that they have enough tanks or cylinders to cover at least 6 hours of O2 use in case the power does go out. Liquid oxygen in a reservoir. If you look at the gentleman there with the little dock at the dock, he has the portable oxygen that's in a small concentrator that is much more portable and much more expensive. Just like the rest of our patients with oxygen, we want to make sure that we maintain their skin integrity behind their ears and in their nose to make sure that they don't have skin breakdown.